Türk Neurosurgery Derneği'nin çok kıymetli üyeleri, sayın hocalarım, çok değerli meslektaşlarım. Bu akşam Türk Neurosurgery Derneği'nin aylık webinar toplantılarındaki konuğumuz Profesör Aaron Cohen-Gadol. Kendisi birazdan bize çok önemli bir sunumunu hazırlayacaklar. Ben de kendisini sizlere takdim etmekten büyük mutluluk duyuyorum. Ümit ediyorum özellikle genç meslektaşlarım için çok yararlı bir sunum olacaktır. It's a great pleasure for us to welcome Professor Aaron Cohen-Gadol from Indiana University in United States of America. I think it is not possible to summarize his academic activities in the World Neurosurgery platform and also his great success in difficult surgeries during daily neurosurgery practice in this session. Besides this, I especially want to mention his remarkable contribution to neurosurgery education with his detailed and instructive videos and cadaveric dissection demonstrations and videos. I'm sure that he will give a guiding lecture which will be remembered especially by our young generation. And also in the meantime, we are also hosting our dear friend Reza as a moderator for this session. And we strongly believe he left half of his heart in Istanbul before going USA. And my words over to him right now. Please, Reza, you can start.
Thanks, Emel. İyi akşamlar değerli meslektaşlarım. Ladies and gentlemen, this is a great honor to be here and to meet with all of you. I left more than half of my heart in Istanbul, so and the other half is in Shiraz. So great pleasure and honor to present Professor Aaron Cohen-Gadol, my dear friend and my country gentleman. We are from the same country. He was born in Tehran. I was born in Shiraz. Of course, he's much younger than me. So, no. Professor Cohen-Gadol moved to the United States in a young age. He was graduated from University of California at San Diego with major in biomedical engineering and minor in jazz music ensemble. So you can see how colorful he has been from the beginning. Neurosurgery residency, medical school in the same university in Los Angeles, University of California, residency in Mayo Clinic, and then as a maybe Iranian disease, he has done completed three fellowships in tumor surgery in Mayo in Yale with I'm sorry, I had a problem with epilepsy surgery and brain mapping, skull-based and cerebrovascular surgery in Arkansas, and surtaxic and functional neurosurgery and radiosurgery. And he has really contributed a lot to the world of neurosurgery. He has been a good teacher. He has been teaching all of us, and we are watching his surgeries, his webinars, and his guests. So he has worked as CEO and president of the Neurosurgical Atlas. And you all remember the operative ground rounds. He is co-director of Indiana University Signature Center for Neurological Disease and Tumors, associate editor-in-chief of Neurosurgical Focus, beside membership in editorial board of numerous journals. He has been author and co-author of more than 460 published papers. His H index is 57, I-10 index is 289. And if I want to go over all his achievements, there will be no time for him to give the lecture. So I will stop here. Aaron, it's a great pleasure to have you. Please go ahead and start.
Merhaba to my dear Turkish colleagues. Emel, thank you. Reza, it's an honor. Hakan, Thank you so much again. It is absolutely a real honor. I know when we give a lecture, we'll start by saying that, but this time it's real. Why is it so real for me and so important to give this lecture to my Turkish colleagues? Because number one, I do believe Turkish neurosurgeons are some of the best surgeons in the world. They're truly the most gifted. I have worked with many surgeons in the world, and the Turkish neurosurgeons are really extremely talented. There's something about them that makes them a great surgeon. Number two, I'm Iranian. Many of my very good friends are Turks, and I have so much respect for the country of Turkey. And also, most importantly, I trained under Professor Yaşargil in Arkansas. So many things that professor, he's the professor, has really created for modern microneurosurgery is truly the foundation for what we do today. So I really want to say series. It just means so much to me. Number one, because I know how important these lectures are. And number two, be able to give this lecture to my dear Turkish colleagues. So with recognizing the great contribution of Bazi Yaşargil in microneurosurgery, I want to start this lecture talking about the experience I've had with really Neurosurgical Atlas and why it was done. The Atlas was really created as a form of life in neurosurgery. The name the Atlas in reality, how it started, refers to the Bible. That's what we use. So the name of the Atlas was really created as the life or the way of living in neurosurgery and the Bible. And that's how we really tried to write it with as the start. This really demonstrates my personal journey with about 7,000 complex cranial operations and about 15,000 hours of surgery. And I'm going to go into the details of what it meant, what I learned, what I could have done better, and really reflect on how important self-reflection, self-learning is in the life of a neurosurgeon. So how did the Atlas start? It really comes from the father of neurosurgery, Harvey Cushing, or the father of American neurosurgery. When I was a fellow at Yale University, I was able to discover the great collection of images of patients and their brains going back to 1892 that are in these jars of formalin. And I really learned how important it is to document your cases from Cushing. This is some of his pictures at the peak of his career that you may have not seen before. The Harvey Cushing Brain Tumor Registry really started from the picture of this young girl on the right side. Somebody lost a tumor, which was a teratoma. You can see that in the right lower corner. And therefore, Cushing got very upset at Johns Hopkins and started his own tumor registry. This was the foundation for the Cushing Tumor Registry that I learned so much from and established the Neurosurgical Atlas. The left side really demonstrates Cushing and his obsession with pituitary tumor surgery. In the 15,000 pictures we have seen with patients of Cushing, this is the only one that Cushing is in fact with a patient and demonstrates his obsession to literally operate on the border of the brain early in his career. This is a video of Cushing operating, but we're going to skip that because of the limitation of time. This is a 2.5-hour lecture, and we want to do it in 40 minutes. So what is clinical decision-making in the operating room? That's what I want to really cover here. What I want to cover is that how do we compare surgeons to athletes and how we can be like one of them? Because surgery and true athleticism are so similar because you have to be very focused, intellectually strong, and physically very enduring. I'm going to show some illustrative cases of how my cases have developed along the years. And I'm going to briefly discuss some of the reflections for residents who are in our audience today. Some of the people that I truly admire so much are somebody like Michael Jordan, truly the master of athleticism. He is so strong, powerful, endurance, thoughtful, and always pushes himself to be the best. Extremely competitive. That is so important in neurosurgery, to be extremely competitive. and was so fierce in always being number one. And that's really what's so important. But why was Jordan so good? Well, he was good not just because he was born with a certain talent, but because he had the right height. If he was more than 6'8", if he was 6'9" or 7'2", like Shaquille O'Neal, he may have not been as good. He had the right hand size, wingspan. Everything for Jordan was that he was born with certain abilities that made him to be perfect, to be light enough to fly, to dunk. He was the right proportion. He wasn't bigger to be less agile. Also, when you talk about, for example, Michael Phelps, the most powerful Olympian of all times, if you look at him and the picture on the right upper corner, you will see that the size of his abdomen and chest to his arms and legs were extremely unusual. So he was born with certain capabilities that, on top of working extremely hard, made him so extremely good. And that's what I want to focus today, that great surgeons are not only made, but you're born. And in fact, you need both to be a master surgeon. And what it takes, does a surgeon think in order to be like an athlete, to be the best? When patients ask me and they say, Dr. Cohen, can you do the best you can in my daughter's surgery? I always say, don't ever ask me to do the best I can. That's just not good. And the patients get surprised. And I always say, don't ever expect the surgeon to do the best they can. You only demand that they do the best anyone can. And that's really the foundation of mastery in neurosurgery, being absolutely the best possible one can be in every way, not only to yourself, but also to others. I start with video of how I sit in the operating room, because I think positioning of the surgeon is the most important. And I always sit. I always go across from the surgical assistants. I always use the mouthpiece, very important, like Yashar Gill created it. And then I always use the armrests to be able to really relax my arms. Those are so critical for us to be in a very relaxed position and do surgery that takes quite a long time. What I referred today about art of microneurosurgery is summarized in this paper invited by Journal of Neurosurgery. It defines the art of microneurosurgery and the passion for technical excellence. So I define neurosurgery not as a doctor. I don't think excellent and great neurosurgeons are doctors. I think great neurosurgeons are artists. They're truly a microsurgical artist that try to act like doctors. We don't want to be doctors who act like artists. We want to be artists that act or try to be doctors. And that's why really, as an artist, it's most important to have an art, which is art of microneurosurgery. Every movement, every handling of the tissue, every transition like a dance. It is truly like a dance. And passion. Those are the two things, the art and the passion of microneurosurgery, and the athlete. Those are the three. The athlete perfects his or her art with passion and practice and self-reflection. So decision-making in the operating room it's a continuum. It ranges from intuitive, when sometimes you do a difficult case and you hardly think because you have done it so many times. And this is subconscious or analytical and conscious when you think a lot. As you become a resident in junior faculty and a senior faculty, you do more surgery and become more and more intuitive and subconscious and less analytical in surgery. And you're able to expand so much of your processing power like a computer to be able to use your processing power like a computer to be able to use it for where you really need it and perform at a much higher level at the most difficult steps of the operation. Obviously, anybody can do it great in an easy operation. That's not enough. Every captain can bring the ship to the shore when everything is relaxed on the sea. It is about when the surgeon or when the captain brings the ship, to the shore when the sea is very turbulent. So it's those difficult cases that differentiate how good we are. And there's a fair amount of pattern recognition involved, that the surgeon flows through the surgery so effortlessly. I look at some surgeons, it takes so much effort for them to do the surgery. And I look at some surgeons that do the same surgery and it looks so much faster, even though they're not hurrying. They're actually going very slow, but every movement does 10 times more action of the other surgeon. So they look slower, but they do the surgery 5 times faster. And that's the art of surgery. How can you do a procedure, look so delicate, look so gentle, look so slow, look like a ballet, not a break dance, and do the work 5 times faster? That is the art of microsurgery that I'm talking about today. And remember, the most common reason for a major complication and error is there's a gap between what you thought you'd see and what you're seeing under microscope. And if you can connect the two, you're going to force your agenda, do something that is not good and cause a major complication. So it's gap in information that leads to that major complication. What is the operative dance? It is truly a dance. And the critical part is one transition from one maneuver to the other. How do you split the fissure and go over the optic nerve and get around the cisterns? If you can do that as if you have done it so many times, if you can do it so fast and efficiently that it feels like you're thinking about other things as you're doing this, and it's so smoothly moving without any non-deliberate, lethargic movements, that's when you're comfortable to the master level. But it takes a long time. You cannot be nervous. You cannot be yelling at the nurse. You cannot be emotionally involved. It is really like a ballet. It looks effortless. It looks so smooth. It's like washing yashargil under the microscope. It just feels like every movement manages 10 different dissection techniques. And that's what it takes to do that as a dance. It is not a break dance. It's not a separated movements. It is a very smooth performance, like a ballet. It's a series of actions for a first and second year resident. They think about, oh, I'm going to cut the skin, put the rainy clips on, coagulate and reflect the temporalis muscle. That's a very early on. Then the senior resident says, oh, I'm going to do the muscle dissection, then I do the craniotomy, then I split the fissure. And then at the higher level, you say, I'm going to do the exposure through the therional approach. I'm going to go around the tumor, and these are the steps I'm going to take. And those steps of situational awareness, that how you're comfortable with every step, really makes that transition from a resident to a senior resident, to a faculty, to a senior faculty, and to a mastery level. In fact, 80% of neurosurgeons never transition from a junior faculty to a senior faculty. They always are the junior faculty, but they're performing just fine. But be able to perform from a junior faculty to a senior faculty, and most important, senior faculty to the real artist, and that's the true artist of microneurosurgery, is really takes almost 15 years of practice minimum, and the 15,000 hours of surgery. There's no way below that. And there's just no way without going to the lab, dissection, surgery, self-reflection, watching your video. I want to really emphasize, every surgery I record, I watch it twice. And I really focus on what I could have done better. And that's, I think, the most critical ingredient. And the situational awareness, where you're so comfortable with surgery, where you eventually walk out of your body and watch yourself operate and criticize yourself. This means you're not emotional in surgery. You're not overwhelmed in surgery, not because you feel like you're so egomaniac that everybody should listen and do what you ask, But in fact, you're so comfortable, as Americans say, in your skin that surgery is the least of your problem. You're just thinking above at a higher level. Your computer works at a much higher level to criticize yourself, to say that, I'm doing great, but I want to do better. I look amazing, but that's not enough. You're operating by your thinking how I could do this better, even though it's going incredibly well, and you're really dancing well. You just want to go a layer higher, a level above. You compete with yourself. You are your worst enemy in your competition. So what is the flow? Somebody, Mihaly, has described this. Many people talk about it. Best surgeons get into a flow. 5 hours goes by. You never felt it. You start a difficult skull-based tumor or AVM, and 5 hours later, you have no idea what happened. It is a special psychological state of total absorption in the task when his athletes are fully focused on what they're doing. The most critical dimension is the concept of challenge skill balance. You can't just do cases that are at your level, then you'll never be in the flow. You have to do cases that you've not done before, that you feel uncomfortable, and you push yourself. The critical concept of challenge skill balance is important because you have to always focus on doing the case in a more difficult fashion that helps the patient. Longer operative corridors, smaller openings, better outcomes, faster recoveries. It's never enough. If you're doing the operation in 3 hours, next time you do it in 2.5 hours. If your craniotomy was this big, obviously not just to tell people you're doing keyhole, because minimally invasive doesn't mean minimally disruptive. Those are very different terms. So you can do a big craniotomy and be very little injury to the soft tissues or brain, and you can do a small craniotomy for the same procedure and really trash the brain. So these are different concepts, but how can you every case do it better? By watching your video like an athlete who's playing basketball or playing soccer, which I know is so important in Turkey, just like in Iran. So there are other concepts of clear goals on ambitious feedback that are critical, but we're not going to go. That's a whole lecture of its own. Often surgeons suffer from a technique called, or a bias called anchoring bias. I can't tell you how many of my colleagues have done it. I can't tell you how many times I've done it early in my career, and I still do it occasionally, is I think that I'm going to do the surgery that way, and I get into surgery and I overlook cues that tell me I'm on the wrong path. And what happens is I make an error and I have a major intraoperative complication. Sometimes I have a confirmation bias. I seek to find what I want to see in surgery because that's my pre-existing belief. How could I be wrong? I'm a neurosurgeon. I have to be right. That is wrong. That's a wrong strategy. You can't just believe you're always right. Let the pathology and the operative corridor guide you rather than letting your agenda force its pressure on the operative corridor and the pathology. Those are extremely different concepts that are very much different in providing safety for the patient. Always reevaluate in the operating. What are you seeing? Is this what I'm supposed to be seeing? If it's different, why is that? How can I do better? How can I do less injury to the brain? How can I do less dissection? How can I do it faster? How can I do it better? And remember, your colleagues are best friends. I always tell my residents and fellows, when you go for a first job, don't worry about money, location, or anything. Just look for the best colleagues who are going to mentor you early on in your career. That is critical advice for the residents. That is critical for you to become a great surgeon, is going to be your colleagues early on in your career. Please, please, please remember that. It's not about the money. It's not about location. It's not about the respect of the university. It's about your neurosurgical colleagues that are going to mentor you, that are going to help you, and they're going to make you become the master surgeon by supporting you. There is definitely a concept of ability that something you see in surgery is right in your view, but you miss it. It is so obvious in your surgical videos. When you watch this case and you go at night relaxed, drinking your chai or tea, your Turkish tea, hopefully not the coffee late at night, the Turkish coffee, and then you're watching your video and you see, how could I not see that? Because you were so emotionally involved in surgery that you become blind. And that phenomena is so frequent. And there is idea of cognitive overload. After 5 hours of surgery, you're tired. You won't be able to perform as well. And surgeons do give themselves that understanding. They all believe they're machos. They can do anything. We're not Superman or Superwoman. We are very much vulnerable to tired moments and exhaustion in surgery. I'm going to show this video. It's a very simple video because I want all the residents remember that it is so obvious in surgery to miss a cue. So please look at this video. So this is a test of selective attention. How many times do you see the players wearing white past the basketball? Please count. People wearing white, how many times they have passed the basketball? How many passes do you guys think? The correct answer is 15. That was your strategy in the OR. That was what you thought before surgery. But let me see, when you got in surgery, did you see the gorilla? That's an important lesson in neurosurgery. For example, I'm going to show a case. Obviously, you knew I'm going to show a video. And I'm going to start with a major complication because it's all good when the case goes well. I've had many of that. I'm sure you guys have too, Reza, Hakan, and Emil. All of them have had the great cases, but those don't make us a better surgeon. A monkey can learn how to do surgery, but are you going to be able to manage your complications effectively? So this is a case of a young person who unfortunately underwent 4 surgeries by very well-known surgeons in the world, in the United States, in fact, and had a very calcified foramen magnum meningioma. As you can see, the cord is very much thinned, and this thing was completely like a bony tumor. So when I started the case, I had to debulk the tumor, literally using the drill. It wasn't the CUSA, it was the drill that I was doing to debulk the tumor. And I was doing that. I really was helpful. This, as you can see, I'm so proud of myself. I'm doing something no other surgeons have done. And I'm really debulking it to the brainstem. And here is the brainstem. I know you're a little bit disoriented, but believe me, that's the brainstem. I was so happy that I did a tumor that 4 other surgeons couldn't. And look what happened. I lost my composure and the ability that what you think you're seeing is actually different, and there's a gorilla in the room. And in fact, there's a gorilla in the room. And I missed the gorilla. And what was the gorilla? Was the vertebral artery. The vertebral artery was very much plastered by the bone onto the surface of the tumor. It almost looked like an arachnoid band. I became so cocky. I became so confident because I did something nobody had done. I thought that I know where the artery is. I used the microdoppler here, and I thought I'm good to go. I didn't think I heard anything, and I cut the vertebral artery. The gorilla I missed. These are the moments that makes such a difficult difference for the lives of our patients, and that's something we should remember. So always keep your composure. Always remember, when a major error happens in surgery, often it's not the error, but it's the knee-jerk reaction of the surgeon without thinking that leads to the major complication. When a major complication happens, don't do the first thing you can think of. Think about it, take a deep breath, and come back. The red stuff can go out for a while, and there's plenty of it in the patient's body. The blood for a 15-second won't make a big difference in the life of the patient, but a major error in your reaction will. So what are the pattern recognition that I was talking about? And I have to watch my time. So I'm about 20 minutes going through my lecture now. The left video is about early on in my career. The right video is a few years ago. Look at the major difference. The first video, using a retractor, a bigger opening, microscope is not used. It's macroscopic surgery. It's not microsurgical, it's macrosurgical. And a lot of lethargic, non-directed movement, a lot of looking around. This is not a show. A lot of just sort of confirming things that I'm doing the right thing. Not a good strategy. Obviously, a very early faculty level. This is hemifacial spasm, exactly same case, MVD. You don't even see the facial nerve, you just see the root exit zone. You're managing it without a retractor, gentle movements, tissues are handled carefully, and everything is done 10 times faster. And that's the critical step, is be able to do more with less, affecting less structures by accomplishing more on the pathology. And I think that's the goal that I'm talking about today. This is a case of an ACOM aneurysm that ruptured that I wanted to review, but I'm going to go ahead and skip for the sake of time. But maybe I'll just, let me see, maybe I'll show. So this is early on too, a bigger opening on ACOM aneurysm, retractors, and then opening the arachnoid, lethargic movements. And this is the case later of a patient, a family member of somebody who is a surgeon themselves, and a 10 millimeter aneurysm could not be managed endovascularly and underwent clip ligation. We used a supraorbital approach, and it's not the details of the case that are important, because at the end of the day, if the case goes well, that's not much to be bragging about, is what is it that we learn in this case that made us to become a better surgeon. In this case, as you will see in a moment, I placed a temporary clip on A1. Here is A1, but during the case, I forgot to check again and the clip was off. So this is the aneurysm. I started playing with it and it was very intense, very tense because the temporary clip was off. I didn't think to go back to check on the temporary clip. I started forcing the maneuver in surgery and tore the neck of the aneurysm. Very small craniotomy, very deep aneurysm, as you can see here, and I haven't even found the contralateral A1. These are the moments that define who we are. Keeping the composure, don't taking the suction out because the brain would herniate out, and then finding the contralateral A1 in the sea of blood and be able to apply the clip safely. That's the technique that always elevates us to the next level like an athlete. In this case, you can see major flow of blood. I cannot see the contralateral A2. And I went ahead and tried to put a tentative clip. As you'll see in a moment, here I bring a tentative clip just enough to deflate the aneurysm. And that would let me find the contralateral A2, as you can see here, gently coming to view at the tip of the clip. And then I went ahead and adjusted the clip. And this allowed me to be able to clip this aneurysm in the face of torrential bleeding. So these are the thoughtful moments in surgery and not letting your fear overcome your intellectual plan. This is another operation of AVM bleeding that I'm not going to go ahead in too much detail about, but similar concept. Be able to think ahead of time and not be able to jump into a conclusion too quickly. What are our challenges in teaching our residents and junior faculty? The challenges is how do you teach people? The challenge really is how do you teach people to go from a very much regimented analytical conscious movement to a non-conscious, non-analytical flow. And that takes doing more surgeries. But how do you get someone to do a lot of cases? That takes you to the point where you have to choose your first practice carefully, be able to do a lot of cases, and establish yourself. You have to be your best teacher. Sometimes others aren't. In fact, neurosurgeons are never born to be a great teacher. Some of the best surgeons we know are not great teachers. I might even say Professor Yashirgil, incredible lecturer, incredible surgeon, but I'm sure not the best teacher when you're in his operating room, because in the operating room, it's a temple, it's a church, it's where everything, the focus is the patient. I remember Professor Yashirgil and I spent many Saturdays together reviewing videos of his. But in surgery, there was not much teaching. It was all about being able to you yourself. But after surgery, we had plenty of time to learn. So how do you make that transition is critical. This is another example of my fellow that I'm talking about doing a clinoidectomy extradurally on the left side. He's so focused, anchored, the anchoring bias of drilling that he forgets there is a carotid artery on the other side. And what that does is placing too much pressure on your drill, and it leads to a carotid injury. So if you overwhelm your processor with too much analytical thinking, you end up missing cues that will lead to complications. In this case, just for you guys to know, I came in and used the thrombus-soaked cotton and be able to control bleeding. Obviously, primary repair is not possible in this location. And then really use the dura to externalize with the cotton remaining on it and be able to continue with the operation. So left the cotton, let the coagulation system of the patient do its work, and then use the dura to reflect it down and externalize that area, and to use the cranium to close the dura after the medial sphenoid ring meningioma was removed. So every complication does have a good way to deal with it. It's just one has to think about it carefully at the time where thinking seems like the most remotest thing you want to consider. There is a phenomenon, just like emotional intelligence, the most important element of surgical mastery and artistry is surgical intelligence. What is surgical intelligence? It is truly a megacognition. It's a higher level human. It's a superhuman ability that you are able to understand and monitor your own operative movements as if you're your teacher while doing the surgery. Developing that skill, really an incredible resource for a surgeon to be better, very effortlessly. So that's why we talk about surgical intelligence. Are you surgically intelligent enough? There are many neurosurgeons that unfortunately are not, and there are a small group that are truly satisfying the true definition of surgical intelligence. And I wish it was easy to define, because certain things you can't even define in surgery, and that's part of art of surgery. So you're not a doctor, you're an artist. Can you teach an artist about art? I would argue that probably not. All of us have to find the art within us, the way it works for us. Nobody can come teach you. You can see how other people do it, but eventually it's up to you to develop your own art and be very honest about your results. So certain novice surgeons develops these algorithms and gets their processor overwhelmed, where this pattern recognition and this automatic movements can really save you and all that energy to the next level. So what is evolution of a surgeon? To be proficient in two things: variance detection. In other words, I see something that I'm not supposed to see, and how am I going to handle that? And number two, uncertainty management. If you're in surgery and you say, God, this is not what I expected, this tumor is really adherent to the brainstem, or the lower cranial nerves are engulfed, How am I going to handle that? Those two things make the biggest difference in the outcome of the surgeon and the art of microneurosurgery. This is another case of a big major bleeding, but I'm going to skip it for now because we want to have time for more dialogue. But it shows that how important it is to keep your composure. This is a case of a pseudoaneurysm of SCA, superior cerebral artery, where as the intraoperative rupture occurred, and I'm going to show a little bit of video, the microscope light was going out. You can see in a moment, you see the light is going in and out. We have no proximal control on the basilar. There is massive bleeding behind the carotid that's being retracted by the suction, and the light of the microscope is going out. How are you going to handle that situation? Those are the moments that define the best of us. This doesn't just apply to surgery, clinical data. How do you diagnose a problem? How are you not going to be sidetracked? What are the pitfalls? And how do you deal with uncertainty? As an expert in the clinic, do you always look for the inconsistencies and then are mindful of disproving your hypothesis? Or as a resident, you always say, oh, I know this is cervical myelopathy. And I always forget that this could be ALS or something else. Are you going to always consider alternative options, or are you going to be focused that you're so insecure that your diagnosis has to be right and nothing else should be considered? So, how do I prepare for a procedure? I do a mental rehearsal, completely like a marathon as an athlete. I always anticipate everything that can go wrong and things that I can find differently because I've done it enough. That takes time. And you have an extremely advanced visual spatial organization of the key landmarks in surgery. You just have this almost sixth sense that you can see doing this surgery, you almost can do it the night before, fluidly. And then you don't believe in dogma. You don't believe in just because they teach you that way, that's how you should do it. That's number one error of many surgeons. You have a conceptual map that you feel so confident in your ability to manage complications effectively, and others do as well, not just yourself, that you can take chances by stepping out of what everyone else to do things differently. And that brings you to become an innovative neurosurgeon. An innovative neurosurgeon is the highest level of mastery, where you do things differently that have been consistently taught the same way for 50 years, just like how Yashar Bill did it, how he thought microscope would work. I mean, I remember when microscopes were coming in, when there was an intraoperative rupture, the surgeon, my mentor, would say, take that microscope out of my way so I can see what the hell is going on, because he thought microscope is on his way. In fact, the microscope was the most important thing for him to see what's going on. And now, something bad happens, we say, bring the scope in to see what's going on. So you can see how dogma can be a major problem. There are critical decision points in surgery that you have to be very comfortable. You have to be extremely comfortable for getting out of trouble. That's a number one step in a mastery of technique. Not to be a slick surgeon, not to have great finesse, not to look good under microscope, but your best goal and most important goal is how to manage to get out of trouble. This is, for example, a case of a patient suffering from this tumor, atrium of lateral ventricle. We've always been taught to go through the transparietal approach. Patient has a visual field defect, that's expected. So early on in my career, I said, why not come contralateral, interhemispheric, transprecuneus approach and remove this tumor? I discussed it with a few surgeons. They thought I'm crazy. They said, that is the craziest idea. You're going to go on the normal hemisphere. You're going to make your surgical corridor twice longer and do a procedure nobody has ever done. That is the definition of stupidity. But you know what? It wasn't me that was stupid. I persevered. I went and talked to my colleagues who supported me. did some dissections in the lab, and did this procedure using the exact technique, the contralateral interhemispheric approach. And 4 years later, we wrote a series of 22 patients, none of whom had a visual field cut, 0 chance of complications that was related to the approach, and beautiful outcomes. But if I had listened to those people who said I'm stupid, that was the stupidest thing I've ever heard of that you do, I would have never been able to really devise this procedure. So that's something we want to think about. Same here. If you see this tumor, they would have said midline suboccipital approach. Never consider anything else. Anything else you do will be a huge lawsuit that's hurting the patient. Well, the past 10 years, ladies and gentlemen, I have not done a single midline suboccipital approach. This has been done through a paramedian supracerebral approach, 5 times faster, because the oblique trajectory over the cerebellum gives you more exposure to the posterior brain stem without the Coleman, which is so high, fighting you with many advantages. Same thing, for example, for a pterional craniotomy for an olfactory groove meningioma versus a bifrontal approach. Another one, tumor of the third ventricle. Nobody ever taught me to transect the septal vein and open the foramen. And just doing that, you will save so much dissection through the transchroidal approach. Just that simple idea revolutionized the complications I had in third ventricular surgery. And this is a patient who underwent that procedure. I'm going to go ahead and skip many of these slides. This is 10 commandments, or maybe more, but let's believe this is the 10 commandment of Moses for residents that I want to share with you, or junior faculty. Commandment number 1, force yourself to aside time to think strategically and self-reflect for your goals, for your surgical videos, for your life. Always think what you want to do and be when you're 50 years old, when you're in fact 30 years old. You and us all have a lot to learn. Don't forget, we know nothing. We're just at the beginning of the learning curve. When you finish your residency, you just start your training. Be clear about your next steps and pre-write your CV. When you're 30 years old, your CV will you want to be 55 years old. Takes an art. Only you as a neurosurgeon is responsible for your value. You can't expect respect from the nurses or other colleagues. You have to prove your value. That's not easy. But don't say, I can't do it, or others have done it differently. All of us have to prove to ourselves. Build your reputation. Everybody in your institution will take you for granted. Communicate directly and build relationships. Neurosurgeons are very poor social animals. You have to be a great relationship and network builder. Think above neurosurgery. Operating in neurosurgery is 10% of neurosurgery. 90% of neurosurgery is something else. Relationships, entrepreneurship, practice building, innovation, research, those are 90%. If you're in surgery and you're a great surgeon, that's good. But you have lost the rest 90% if you don't do the rest. What are the critical ingredients? Be trustworthy, do independent learning, have attention to detail, and manage your time efficiently. Being in the operating room is not 90% of neurosurgery. Remember that. If you spend 90% of your career only in the OR, you're missing a lot. Be personable and a leader. Remember, you can't expect others to make you their leader. You have to gain their trust to be their leader. Being an operator is not the final goal in neurosurgery. Again, a great surgeon, a master surgeon, is not the amazing neurosurgeon. Best surgeons learn from watching. Believe it or not, so much great learning you can do. Don't always expect to let your attendings or senior faculty to let you do the case, because that's what makes you a good surgeon. That's an emotional response. That's not reality. And most important of all, enjoy the journey of neurosurgical training all your life, not just during residency, because truly being a neurosurgeon is not a right, it's a privilege. And truly, we're so gifted and so lucky to be a neurosurgeon and go through this training, which is the best time of our lives. So with that, I want to thank you, everyone, Reza, Hakan, Emil, all my amazing Turkish neurosurgery colleagues that I have so much respect for. Truly, the Turkish neurosurgeons are among the top 5% best neurosurgeons in the world because they come with a tradition of attention to anatomy, surgical excellence, passion, better outcome, and all the Turkish neurosurgeons, like my Iranian colleagues, all of us together, we have this passion for technical excellence. And that passion is truly the fuel, the gas that drives the formation of the master surgeon, who all of us have so much respect for. So thank you for letting me to be part of such an important series of lectures. And I'm happy to discuss and answer any questions.
So thank you so much for this outstanding talk. It shows that during your years with working with outstanding mentors and teachers, you have not only been watching, but you have been seeing and thinking and processing things to innovate and make the things more beautiful, like to advance the art. So thank you so much. We can get some questions. So one of the questions coming is, how do you adjust your daily life to get to this level of excellence?
Excellent question. The best question. By the way, who asked that question? Was it one of you guys or one of the junior faculty? Who was the person who asked that question?
It was one of the audience, yeah.
Beautiful. Whoever asked that question went to the absolute heart of the matter. Because if you focus always being in the lab, in surgery, you can really be there for a long time, more than 24 hours a day. So how do you spread your time efficiently to be a great surgeon, great researcher? But let me get the order right. How can you be the best father, the best husband, the best friend, the best surgeon? That's the order. You don't change that order, please. I believe great surgeons first are a great father and a great husband. No question about it. Why is that so critical? And how do you manage your time to make that possible? You don't have to be there for the entire surgery. You're going to train people who are going to help you, and you're going to become so good that great people want to work with you. And when you have quality people spending time with you and you have good mentorship, you're going to have talented people that are going to create time for you. The patient care will not be compromised, but you train people that you need to be in surgery for a period of time that are so critical, and you are able to gauge other people's talents so well that the surgery will in fact have been more successful if you had not been there the whole time. So we have fellows who help. I have learned how to be more efficient, and therefore I am able to do much more in surgery with a shorter period of time. That's number one way to do things. Number two is, as a neurosurgeon, you can't believe that you are the only person in the team. You have to delegate, but you have to delegate effectively. That's an extremely important art. You can't just get 5 people that are interested in working with you, bring them in, and now we're ready to go. It takes years of training the right people and having the right team. Just like in business, the most important success in the business is not an idea, it is execution and the team. Do you have the team, and can you execute? I have dinner with my family early evenings, 95% of the time with my children. I believe strongly spending 70% of the time in the weekend with my children. Those are critical. I believe I have to spend time to have an executive coach to teach me how to be a better person. I have time for research. I have time for surgery. I do all of that. But I don't believe that I'm the only person who is the team. I have a great team who I've trained, who trust me, and I trust them, not just because they wanted to work with me, because we have worked together for many years. That's how you make yourself efficiency. I might argue that the idea of the great neurosurgeons we know in the past, where they did everything on their own, is not going to be successful now and would actually lead to failure. You have to have a better plan to do 3 times more work and still have plenty of time with your family. It is possible, but it takes an art. And that's why I said neurosurgery is 10% operating, 90% something else.
Thank you so much. One other question is, what's your opinion about the amount of time someone should spend in anatomy lab?
Yeah, you know, that's a little bit overemphasized. I know Professor Yashirgil and a lot emphasize spending time in the lab. I do as well, but you can overestimate the power of the lab. I would say you have to spend a fair amount of time, maybe, 2 years intermittently in the lab, or 1 year concentrated in the lab. And then after that, you have to really go to the lab as you need it. You can do great things in the lab. And I know surgeons who can do magnificent dissections, but they're terrible surgeons in the operating room. The dissection in the lab and the operating room are extremely different. You need the lab for the OR, but that's not everything you need. There's a lot of other things. So just because you stay in the lab and do more work doesn't make you feel more comfortable to be a better surgeon. Actually, it can fire back because it gives you this confidence that is not real. So I think there is certain steps of mastering surgery, mastering the lab, and sometimes they don't overlap. There's certain steps overlap, but if you just master more and more in the lab and fall behind in surgery, you're still here. You're not up here. You have to move together to be where you need to be.
I agree with you. Too much time in lab might make you an iron hand person.
Absolutely. It actually may lead you to be a worse surgeon because you're so confident. I spent 5 years in the lab. I'm a great surgeon. Absolutely not. That can be a major bias that can lead to disasters.
So you talk about endurance during surgery.
Yes.
And what's your opinion about staging procedures, or do you prefer to go at once?
Yeah. Early on in my career, I used to stage big skull-based tumors and giant AVMs. I don't know of any giant AVM that has taken me more than 4 hours now. Why is that? Why did it go from 12-hour major 6-centimeter AVM to 4 hours and very comfortable? It was an ability to know what I can get away with. It was that confidence that the blood not bothered me anymore. And in fact, I found out that if your operative field in AVM surgery is always clean, you're doing something wrong. AVM surgery is like riding a plane. When the plane takes off, it's turbulent. When you get down to cruising altitude, it's comfortable. But for you to land, you got to get into turbulence. You can either be in the cruising altitude for a long time and miss your target, or you can get into the turbulence and come down. So what's the difference between uncontrolled chaotic bleeding that is dangerous and controlled bleeding that is making you more efficient? That gets experience. But the way I made the decision is that I pushed my limits of what I can get away with. And that's very difficult to define. And I would say at this point, very rarely I stage. I do believe in staging earlier on in your career. If you're operating after 4 o'clock and you started your case at 8 a.m., you close. Doesn't matter where you are. I don't operate after 5 p.m. That's just never, ever, because you're not going to be in a good shape. You may feel like you're in a good shape, but you are altered. You're not who you are because your mind is believing in something that's not real. And that's what I talk about surgical intelligence. Be able to mentor yourself. Because our mentors told us, oh, surgeon, you have to operate for 30 hours. So I stage only petroclival meningiomas. Absolutely, I do. Because I want to be home at 5 p.m., having dinner with my family, and know that I'll be a much better surgeon for the patient next day. So staging, absolutely. Very rarely, because we use so many other skills to make those longer surgeries much, much shorter.
Thank you so much. So I guess there are no more questions. Our Turkish colleagues are getting ready for dinner. You know, dinner in Turkey is a little bit later than.
What time is it in Turkey?
It should be 9 p.m. now, right?
9 p.m. So after dinner.
Okay.
So
Yeah.
they should have already put the kids to bed, read the book with them, which is so important. Having dinner with children and wife, spending time reading books, and thinking about your family are absolutely critical in the lives us as neurosurgeons.
So it was a great talk, Aaron. Thank you so much. As usual, I enjoyed a lot.
It was more of a personal talk. Yeah, it was more personal. I think people always want to know how I do things. And I wanted to open my heart to my Turkish colleagues and say that this is how I do things. This is how I live life. These are my secrets. I can show you guys, a lot of surgery videos. There are plenty of amazing surgeons among the colleagues today. It's about who am I? How have I done it? And this has worked with me, I think, for me. And I think that's what most people want to know when they talk to me personally.
That was great. I would like to thank you so much, and I will leave it to Emel for closing the session. Thanks, Aaron.
Sure.
Professor Gado, it's an extraordinary lecture. Thank you. And I do hope in the near future, after the pandemic is over, we will be able to meet at real Congress. And until that day, I do hope, I wish you to accept my deepest thanks and hope that you will be safe and you will be always our close friend. Thank you again. Thank you again.
Thank you again for the honor.
It was a great contribution.
Thank you for the honor. So much respect for my Turkish neurosurgery colleagues. God bless you. God bless you. And I wish.
Reza, bye bye.
Thank you. Bye.
Bye.
İyi akşamlar.
Thank you. İyi akşamlar.